Welcome, everybody, all participants and attendees. It's my pleasure to welcome you on behalf of the Genes and Kidney Working Group and the Immunonephrology Working Group, together with my colleague Annette Bruchfeld. We have very prominent speakers and panelists today on the topic of precision medicine and hierarchy of diagnostics and treatment in haematuria, proteinuria. So it's a very vast topic, but we want to discuss examples of how to prioritize diagnostics in the era of next generation sequencing and genetics first approaches. And I'm happy to welcome, first of all, Bertrand Knebelmann. He's a professor of nephrology at Necker Hospital in Paris, and he's a renowned expert on hereditary kidney diseases, Alports, but also ADPKD, cystic kidney diseases, and hereditary kidney stone diseases. And then later on, we will have a presentation representing the immunonephrology topic by Elion Hoxha from the University Hamburg. He's an expert on membranous nephropathy and a professor on nephrology as well there at the University Hospital. And he will give us some examples on the immunonephrology side and the perspective of the immunologic proteinuric kidney diseases. I'm now happy to hand over to Annette for introducing the panelists, and then we can get started.
Yes, thank you very much. So it's my great pleasure to introduce our panelists, who are also very prominent. First, Professor Daniel Gale at University College London, who's an expert on genetic kidney diseases. And then Peter Boor, who is a professor in pathology at the Institute of Pathology at the University Hospital Aachen in Germany. And we are looking forward to your presentations and discussions. And for the audience, you feel free to add any questions in the Q&A box during the talks.
So hello everybody, thank you for the organizer to invite me. I'm not sure if I should thank you to invite me such a broad topic. So we're going to talk today on precision medicine and glomerular disease, and I'm going to focus mainly on the problem of haematuria. How do you approach a patient with haematuria first? I have not much to disclose. So in nephrology, of course, we must first exclude a non-glomerular source of haematuria by the traditional exam, and including CT scan usually, and sometimes cytology and cystoscopy. Once this is done, we look for the glomerular haematuria. In some countries, you have easy access to microscopic examination for red blood cell cast, dysmorphic renal blood cells, not very sensitive and not done everywhere. And the initial evaluation, you know very well, the patient history and physical examination, and you're going to perform a few immunological tests that Elion Hoxha is going to talk about later on. I'm going to focus here in the case where you have no abnormal immunological test. In this case, you're going to ask if the patient has a known family history or physical feature of Alport syndrome, because it's one of the main cause of isolated hematuria or hematuria with small proteinuria, especially in the young adults and of course in children. You're going to look especially for external symptoms, hearing loss, and ocular findings. Just a few words. The hearing loss in Alport syndrome begins in childhood, but not early infancy. Patients are never mute. It begins on high frequency, so it cannot be detected sometimes just by the patient, and you have to perform an audiogram, and it's inconstant. So absence of hearing loss, of course, does not exclude Alport syndrome, and it starts on the high frequencies as shown on this audiogram. Regarding the eye lesions, they are pathognomonic but inconstant, present only in 30–50% of the patients, especially the severe forms, and they can consist of anterior lenticonus, which is quite specific of Alport syndrome, or on the posterior part of the eye, on maculopathy with perimacular flecks that you can see here, and you have to ask specifically the ophthalmologist to look for these signs. These signs are not always present. If there is a family history or these signs are present, the diagnosis of Alport syndrome is very likely. And you're going to ask if there is a family history, if a genetic testing has been done already. If not, you can discuss in front of a patient with isolated haematuria to perform a kidney biopsy or to perform conservative monitoring, and which is just a follow-up of the patient. So what can be the advantage of kidney biopsy? It can help to distinguish between the most common cause of isolated haematuria, IgA and Alport. Of course, the risk should be weighted against the potential benefit of establishing a diagnosis. It can help to predict the prognosis, the genetic counseling, once the diagnosis of Alport syndrome is established, and of course, lead the patient towards potential therapies. But when the patient has isolated haematuria, there's no specific therapies, neither for Alport nor IgA. So conservative monitoring is an option, and you have to follow annually protein and microalbumin expression. Don't forget microalbumin. And the kidney biopsy can be performed when microalbuminuria appears, because in this case, it could lead to starting treatment with RAS blockade, especially in the case of Alport syndrome, where it has been shown to be effective. The opposite in IgA nephropathy, it's not well established that it's effective. When you perform kidney biopsy, the histology is often normal. You have podocyte hypertrophy, especially if there is a high proteinuria, but otherwise no. You can have moderate thickening or thickening of the GBM, especially with Jones coloration. And in more advanced form, you can have FSGS, non-specific FSGS. So you have to look for more specific signs and especially ask for electron microscopy. It's crucial if you suspect Alport syndrome. The lesions are very heterogeneous, can be the typical irregular thick and thin GBM, like you can see here, thin here, and very thick here. And but also it can be thin GBM only, as you can see here. And thin GBM is really a pathological lesion. It can be seen in child with any form of Alport syndrome, and it can be seen in adults with autosomal dominant form of Alport syndrome. So this is a very important message. Thin basement membrane is an historical lesion. It's not a disease entity. And the term thin basement membrane nephropathy should not be used anymore, even if I know many people have hard time to drop this terminology. So you can use also immunochemistry. Immunochemistry, to understand the interpretation, you have to understand the biochemistry behind Alport syndrome. There are 4 genes responsible for Alport syndrome, the alpha-3 and alpha-4 chains encoded by gene on chromosome 2, and when they are mutated, they are responsible for the autosomal form of Alport syndrome, and the COL4A5 gene on chromosome X. So in the GBM, you have a 3, 4, 5 complex, and you can use an antibody against 3 or 4 or 5 chain to look if it's present or absent in the GBM. In the skin, you have another network with 5, 6, 5, and you can use an antibody against alpha-5 chain to see if it's present or absent in the epidermal basement membrane. So look at the kidney. If you look at expression of alpha-5, if you have a mutation in alpha-5, you will have disappearance of the whole structure of 3, 4, 5 complex. And in 75% of the cases, you will lose completely the normal staining along the GBM, the Bowman capsule, and some of the distal tubules of the alpha-5 chain. In the case of a woman with X-linked Alport syndrome, you have a mosaic pattern because she has two X chromosomes, and we have part of normal staining and part of abnormal absent staining for the alpha-5 chain. This necessitates a good technique. And if you have autosomal recessive Alport syndrome, you have a mutation in alpha-3 or alpha-4 chain, it will usually disrupt the whole complex, and again, you will have no staining on the GBM of the alpha-5 chain here in green in the control, and you have persistence of alpha-5 in the Bowman capsule and in the collecting duct, where alpha-5 can be expressed in the absence of 3 or 4. An alternative to the kidney biopsy can be the skin biopsy, which is less invasive. It's only if you suspect X-linked Alport syndrome, because you can be able to explore only the alpha-5 chain. In the normal skin, alpha-5 is expressed in the skin, and in most cases of all X-linked Alport syndrome, you have disappearance of the alpha-5 chain in the skin, and in the female, again, a mosaic pattern. But again, a normal biopsy does not rule out Alport syndrome. It can be normal in both X-linked Alport syndrome and in all cases of autosomal recessive or dominant Alport syndrome. So once you know that the family has, the patient has a diagnosis of Alport syndrome that is very likely, you ask if genetic testing is available. If the family in the family a known genetic mutation has been shown, of course you're going to test specifically for this mutation and see if the patient has the same mutation as other members of the family, and if yes, the diagnosis will be established. If no, you will have to look for other disease in this individual. If there is absolutely no genetic testing available from other members, you will perform next generation sequencing by different panels of col4a4 gene, some panel for FSGS, around 70 genes, renome whole exome sequencing or whole genome sequencing. And you will look like for pathologic col4 mutation. And you have to be very careful because you need to see the report of the geneticist and to see if it's really a pathogenic or likely pathogenic variant, which is called class 4 or 5 of the American College of Medical Genetics. Because sometimes you have a variant in the col4 genes that are known significant, called VUS, and in this case, you cannot conclude that the variant is responsible for the disease. And of course, it's very important. So if you have a variant, the diagnosis is established. If no, and sometimes when there is a variant of unknown significance, you have to perform kidney biopsy with the tools we have seen to try to confirm or not the diagnosis of Alport syndrome. When there is no family story, no extrarenal feature of Alport syndrome, you can discuss again the kidney biopsy. And if there is any feature of this, the diagnosis is likely and we will perform genetic testing. So finally, when is it reliable and desirable to do kidney biopsy for isolated haematuria with no family history? It's particularly important in women of procreative age to do this testing. Why? Because you can have X-linked Alport syndrome in this woman. So if we summarize the mode of inheritance, we have X-linked in the majority of cases. It was said 85%, now it's more 60%. We have autosomal recessive in 10%, and the more and more frequent autosomal dominant form in around 30% of the case. So if you have a woman with no family story, isolated haematuria, she could have a col4a5 mutation, for example, glycine substitution, telling us that she has X-linked Alport syndrome. And if she has children later on, she will have a 50% risk to have an affected son with will be hemizygote for the same mutation and who is at risk of severe X-linked Alport syndrome with 50% ancestral disease at the age of 25 and early hearing loss. So that's why it's very important to perform a diagnosis in this woman. So the spectrum of phenotype associated with heterozygote COL4A3, COL4A4 is very large. They can have no haematuria. Most of the time they have isolated haematuria, and they can have proteinuria, CKD, and late onset and stage renal disease. That's what most of the people now we agree to call this autosomal dominant Alport syndrome, even if it's in some families, it seems to be only benign familial hematuria. These variants are very frequent because recent work by Gibson et al. And Danny Gale, one of our panelists, shown that one individual out of 100 carry an heterozygote COL4A3 or 4 variant. The risk of developing ancestral disease is very different. For example, in male X-linked, it's 100%, in female it's 25%, and in autosomal dominant form, it seems to be around 20% only to develop ancestral disease. This variant can be also found in other forms of glomerular disease, in focal segmental glomerulosclerosis, more and more both in familial and sporadic form. You have this variant, and also in so-called familial IgA nephropathy, more and more it is found that this case are true Alport syndrome and not familial IgA nephropathy, and we will discuss this later on, I'm sure. So this box summarizes the indication for genetic testing for Alport syndrome in the different situations that we've seen with glomerular hematuria, all the more if there is one of the different findings that we discuss, both clinical, family history, and pathological, or we will see steroid-resistant FSGS. The benefit of genetic testing is important to stop the odyssey, to establish a better prognosis, to avoid an unnecessary treatment, for example, for FSGS, for genetic counseling, for early detection of at-risk siblings and early nephroprotection, to help secure kidney donation, to enrich rare disease registry, and to participate in new therapeutical trials, and probably the near future for personalized treatment. In fact, there are no specific treatment for Alport syndrome available today. There have been recent trials that have been unsuccessful, Bardoxon trials that has been stopped, as you know, and the anti-MIR21 trial, very promising in mice, but futility analysis stopped the trial in human. RAS inhibitors is the main treatment, like in many glomerular disease, and is particularly effective in Alport syndrome. And recently, SGLT2 inhibitors have been added to the therapeutical potentials that we have. We don't know yet if it's specifically available, efficient in Alport syndrome. And in the near future, we'll have some gene editing technique that could be very promising. When should we start ACE inhibitors? Probably very early at the stage of microalbuminuria. Study by Oliver Gross, Early Protect Alport, tried to show this, but it was underpowered. So I think we have to wait for the stage of microalbuminuria and not start treatment at the stage of microhematuria, but some authors suggest that we could, even before microhematuria, start RAS inhibitors. And there are many trials ongoing, both preclinical and clinical, in Alport syndrome, and including with endothelin receptor antagonists like sparsentan or atrasentan. For the patient with nephrotic syndrome or heavy proteinuria, without haematuria usually. The first thing is to search for extrarenal features and a family history that could lead toward a genetic disease. A lot of different extrarenal features can be part of syndromic proteinuria. It can be hearing loss, it can be nail or patella abnormality for nail patella syndrome, genital abnormalities, eye abnormalities for the papillorenal syndrome, eye abnormalities again for LCAT deficiency, neurological peripheral disorders for Charcot-Marie-Tooth, macrothrombopenia for MYH1 related disease, or angiokeratoma for Fabry disease. So you really need to perform a thorough clinical exam in front of any patient with proteinuria. And most often there are no extrarenal features, and the kidney biopsy is going to show FSGS or sometimes normal optical macroscopy, and the electron microscopy sometimes can help to establish the diagnosis of primary FSGS compared to secondary FSGS. And when the genetic test should be performed according to the KDIGO recommendation, if you have a nephrotic syndrome, you will treat like idiopathic nephrotic syndrome with steroids. And if there is no response, you have to consider very rapidly genetic testing, especially in people younger than maybe 40, 50 years of age, to stop ineffective immunosuppressive treatment if it's a genetic disease. But even in the absence of nephrotic syndrome, if you have nephrotic range or even low range proteinuria and FSGS at the kidney biopsy, you have to consider genetic screening, especially if it's progressive installation of the proteinuria. And this will avoid unnecessary immunosuppression and allow only supportive therapy and familial screening if it's a genetic disease. The yield of genetic testing steroid-resistant nephrotic syndrome has been assessed in a very large study by Frieda Hildebrandt and many co-authors recently, and it was around 30%, which is very high, mainly in sporadic case and also in some familial case, but these were before 25 years of age. And a few words to end on ApoL1. You know that the ApoL1 risk variant are present in 30% of people of African ancestry in America, but also in Europe. And it's a very high risk for some renal disease, HIV-associated renal disease, FSGS, as you know, but also proteinuric non-diabetic chronic kidney disease at large. So the genetic testing should be performed in this patient with FSGS or steroid-resistant nephrotic syndrome, but also ancestral disease of unknown etiology, and maybe now hypertensive chronic kidney disease, and of course in a specific case like lupus or sickle cell, it can have a prognostic advantage. And the advantages are numerous. It can help better understand the etiology, especially to distinguish from primary FSGS of immune origin, to institute preventive measure for the progression of the disease, to predict the kidney function course, to inform the family member at risk, to help for the decision related to kidney transplant, and to identify patients for clinical trials, especially now there are 2 drugs that are tested in trials for ApoL1 mediated kidney disease. And with this, I will end and I will respond to your question. Thank you very much.
Thank you, Bertrand. I'll hand over to Daniel for a discussion, a brief discussion, I have to say.
Thanks very much, Jan, and thanks, Bertrand, for that wonderful and very clinically useful talk. I'm thinking about how treatments and prognosis in Alport syndromes changed over time. We know that reading the literature or the internet can be very frightening for patients recently diagnosed with this. But given the broader spectrum of severity seen, particularly with some of the missense mutations, and also the growing power of therapies, even RAS blockade and potentially SGLT2 inhibitors, how has your prognostic advice to patients changed when you diagnose them with X-linked Alport syndrome? And to what extent do you think that the actual mutation affects this advice?
It's a difficult question. You have to be very careful because the genetic heterogeneity leads to large heterogeneity in terms of prognosis. And even if you know the gene affected, the mode of transmission, it's very difficult at the individual level to predict the prognosis. For X-linked male, it can be, and central disease can be 15 years and 70 years of age, even for a male. So it's very difficult to predict. From what we've seen, there is no much progress. We try to look at the age at ancestral disease. There's a tendency towards the later age in the recent decades, since we use ACE inhibitors, but definitely it's not a cure. It retards the progression. Regarding SGLT2 inhibitors, I cannot say. I've treated a lot of patients, and Oliver Gross will present at the ASN in the late clinical trial session the result of a survey that he did, including our patient in France, but also in the US and different countries, regarding the effect of SGLT2 on Alport syndrome, but I'm not sure it will be powered enough. Now I tell my patient I'm hopeful that a lot of research, a lot of biotech and pharma that are interested in Alport syndrome, because there's a good mouse model and a lot of trials are going on. I didn't have time to mention with drugs that go through non-stop mutation, with drugs that act on the lipotoxicity, with drug which acts on chemokines. So a lot of trials are going on. I'm hopeful we'll have something more innovative in a few years.
Thanks very much. And I guess the other question I had was related to the genetic testing for APOL1 mediated kidney disease. And really, given the high frequency of high-risk genotypes in some populations, what advice do you give people who are found to have two high-risk alleles but have no evidence of kidney disease? How should they see their relationship with their kidneys moving forward? Are they at risk of developing kidney failure? Should they see doctors frequently, or should a more expectant approach be?
Yeah, it's an excellent question. I'm not sure I have the exact answer. We don't perform so often testing of asymptomatic siblings of a patient with APOL1 high-risk variant, even if when we counsel them to perform the tests, more than often it's difficult to see the patients. They don't want to be. So is there an advantage? I think yes. I, for example, detected a young girl, age 17. She was a sister of another girl affected with nephrotic syndrome, quite severe. And I tested her, and she had proteinuria around 1 gram, totally asymptomatic, and I could start a treatment. Now, if they don't have any proteinuria, I will just suggest to perform each year urine analysis, no blood sample, just to see if microalbuminuria or proteinuria appears, and start RAS blockade if it does. So I think that's really an advantage to be able to detect early the proteinuria.
Thanks very much.
Yeah, and of course there are trials going on, both with inaxaplin that most of you have seen in the New England Journal of Medicine a few months ago, which is promising, and with antisense oligonucleotides that are starting also.
Thank you, Bertrand. Thank you, Daniel. I think in the interest of time, we need to move on, and I'm happy to introduce Elion Hoxha, the stage is yours now, Elion.
Thank you very much for the invitation, the possibility to talk today. So the topic of my talk is precision medicine and hierarchy in diagnostic and treatment of haematuria and proteinuria. And of course, and I will focus on immune-mediated kidney diseases on my talk. But however, discussing the diagnostic and treatments of all immune-mediated glomerular disease would, of course, take not only 15 minutes, but much more. So that's where I will focus a little bit more on the specific diseases in this talk. So these are my advisory board and my conflict of interests. So if we talk about immune-mediated glomerular diseases, then we should keep in mind that this is not one specific disease, but this is a number of different disease entities which have very big differences in the pathogenesis, in the histomorphology presentation, as well as in the clinical presentation. So although these underlying diseases of glomerulonephritis are very rare, they are a common cause of end-stage kidney disease, and that's why it's important to better understand how they are caused, which are the pathomechanisms behind these diseases, and how we can diagnose and treat them better. However, because of these different pathomechanisms, which is also shown in the different histomorphology of these diseases, the outcomes and the prognosis of each patient is different, and that's why also the way how we diagnose and treat these patients must be different. So, for example, in ANCA-associated vasculitis, we have a very rapid loss of kidney function without treatment. So the treatment, the immunosuppressive treatment, will be very rapidly implemented, while this is completely different in membranous nephropathy, which is developing rather slowly. So how do we move on in our patients to diagnose these diseases? Well, the first problem is, if we think of our practically of one patient of us, a 60-year-old patient who comes to us. This patient, of course, he doesn't come with, I have ANCA-associated vasculitis, or I have membranous nephropathy, or I have FSGS, so what should I do? Or I have this or that pathomechanism disease. What the patient brings us is this. So the patients can bring us a nephritic syndrome or a nephrotic syndrome. And here is where we actually start with our differential diagnosis of our patients. So if the patient will have a nephritic syndrome, he will have dysmorphic erythrocytes in his urine, he will have hypertension, proteinuria might be present at various degrees, and in some cases he will have a acute kidney injury, for example, serum creatinine 2.8. Of course, the different with the situation, the clinical situation, considering the further diagnosis and treatment of the patient, would be completely different if this patient would have a nephrotic syndrome. So this patient might have a very large proteinuria, for example, 12 grams per day, quite well preserved renal function with a serum creatinine of 1.0, would have a hypoalbuminemia, and would have edema. So how do we move on in the further diagnostic of these patients? If we start with the patient with a nephritic syndrome, who has a proteinuria of 1.1 and a serum creatinine of 2.8, there are a very large number of kidney diseases which might explain these findings in these patients. All of these are considered immune-mediated kidney diseases. However, each of these is very different. And in this situation, the kidney biopsy is needed for the diagnosis of the patients, but also for treatment decisions and prognosis estimation. Depending on the disease which will be diagnosed at the kidney biopsy, of course, the potential of making further decisions or the value of the kidney biopsy in this patient might be different. For example, in IgA nephropathy, the kidney biopsy is practically the only way of diagnosing this patient that he has this disease. In ANCA-associated glomerulonephritis or an anti-GBM disease, the treatment decisions must be taken very rapidly, and the treatment must be initiated very fast in order to preserve kidney function. In diseases such as the MPGN-C3GN complex, the kidney biopsy would lead to very important information considering the differential diagnosis of these patients and to find the true reason behind this diagnosis. So, especially in cases in which an acute kidney injury is present, meaning this patient would have a rapid progressive glomerulonephritis, the rapid initiation of the appropriate treatment would be extremely important, like in ANCA-associated glomerulonephritis or anti-GBM disease. In some cases, Serologic, complement, and genetic testing would provide important diagnostic and treatment information. For example, in the complex of MPGN and C3 glomerulopathy, that would lead us to better differentiating whether this patient would need an immunosuppressive treatment because he, for example, has an immune complex disease, whether this patient has an immune complex disease because he has an hepatitis C, where we would treat, of course, the underlying disease, or whether this patient has a complement disease where the treatment would go to complement inhibitors. The situation is a little bit different if our patient would have a nephrotic syndrome. For example, very high proteinuria of 12 grams per day and a serum creatinine of 1.0. Until 10 years ago, I would have said in this situation almost the same thing I've said in the patient with nephrotic syndrome. So in all of these patients in the kidney biopsy, and there is no chance of making a diagnosis of these patients without the kidney biopsy. However, in the last 10 years, the situation in some patients with nephrotic syndrome has changed. Why has this situation changed? One of the reasons is because for many, many years or many decades, diseases like membranous nephropathy of FSGS, which are very common causes of nephrotic syndrome in adults, were defined as a pattern of injury in the kidney without specifically knowing why this disease is being caused. In membranous nephropathy, we knew for a long time that some kind of antibodies are inducing the disease. However, we didn't know against which target antigen these antibodies are directed and why these antibodies are being circulating. So thus, the treatment of the patients would also be based on the data like proteinuria and serum creatinine, which would not only show the disease activity, but also the damage in the kidney. So that would make a little bit more difficult to decide whether this patient has active immunologic disease or not. In FSGS is, of course, much more difficult because in FSGS you have a very large number of underlying diseases. You have the genetic causes of FSGS, and then you have, of course, the primary cause. So this differentiation between the primary autoimmune causes of the disease or the secondary causes associated or caused by other diseases has been somewhat helpful. However, better understanding the pathomechanism behind the disease would make possible that we have major improvements in the diagnosis and treatment of these patients. So how would it look like? First, we would have the possibility to have a more pathomechanistic view of the disease. For membranous nephropathy, this was possible with the identification of the PLA2R as the major target antigen in 75% of patients where the PLA2R antibodies cause this disease. This makes possible that the diagnosis of the disease can be made on the pathological molecular pathomechanisms by staining the kidney biopsy for the respective antigen or by measuring the PLA2R antibodies in the blood. Until now, a number of target antigens in membranous nephropathy have been identified. Thus, for the diagnosis of the disease, we have the possibility to perform this with a kidney biopsy with a staining for the respective antigen, for example, PLA2R or THSA7A in this second case. On the other hand, we can also use the identification of the respective autoantibodies in the blood for the molecular diagnosis of these diseases. Why is this possible? This is possible because there has been many studies showing that the specificity of the identification of these autoantibodies in the blood for the diagnosis of membranous nephropathy is almost 99 to 100% for both PLA2R and THSA7A. The data for PLA2R are much more robust because these patients are much more common. 75 to 80% of patients with membranous nephropathy has this form of disease compared to patients with THSA7A associated membranous nephropathy. So, do we need in all these patients still a kidney biopsy? Well, there have been some studies analyzing this, whether we need a kidney biopsy for the diagnosis of membranous nephropathy in these patients who would have a PLA2R positive serology. However, we should consider how these studies have been built up and how the protocol was. So in this study cohort published 2 years ago, the authors identified 276 patients with a positive PLA2R serology. And then they excluded patients like children or kidney transplantation, patients who had associated diseases like autoimmunity, malignancies, diabetes, and patients with a not well-preserved kidney function, so with an eGFR below 60. And if you exclude all these patients from the analysis, in none of the remaining 79 patients did the kidney biopsy results lead to any change of treatment compared to the treatment which would have been performed only with serology. In the second study, we performed an analysis which was quite similar to the colleagues shown before. We studied 194 nephrotic patients who also were tested positive for PLA2R antibodies. In 94% of these patients, the kidney biopsy revealed no further diagnosis than the PLA2R-associated membranous nephropathy, while in the remaining 6% of patients, a second renal diagnosis was made by biopsy. This was interstitial nephritis, diabetic nephropathy, or IgA nephritis. And when looking at the clinical characteristics of these two groups, we also saw that the patients where a second biopsy was, where a second diagnosis was made, were patients of the kidney where the kidney function were less well preserved, with an eGFR of 50 compared to the eGFR of 84 in the group of the patients who had no further diagnosis. So, when considering whether we need to make a biopsy in the patients with PLA2R antibody who is nephrotic or not, we cannot, in my view, we cannot respond by doing for all patients the same, but we have to go into a more individualized decision making. So, how is the proteinuria the clinical presentation of these patients? Is there something abnormal? So, are the antibodies going down while proteinuria is going up, or the antibodies are going up and vice versa? How is the kidney function? How are the antibodies? How high are the antibodies? Are they positive, negative? How they are moving? Are there urine abnormalities? Is there, for example, a glomerular hematuria? Is the medical history indicative or of any differential diagnosis in these patients? And of course, how is the risk profile for the biopsy? Meaning, is there an anticoagulatory treatment for these patients, which might make the risk of the kidney biopsy higher? A very important point is, of course, that by performing the kidney biopsy, we don't only find the diagnosis of a PLA2R-associated membranous nephropathy, but we also gain very important information which might help us in our decision to treat or not treat, and how long to treat and how to treat the patients. This would include hypertensive damage in the kidney biopsy, whether there is a chronic disease, how is the stage of the fibrosis. We can find the electron microscopy, MN stage, and of course, there are the important findings, which might be incidental biopsy findings, which might be rare, but they are there. For example, there have been some cases described of patients with PLA2R membranous nephropathy who at the same time had amyloidosis. There are rare cases, however, for the patients having these diseases, finding it would be very important. Last but not least, for near the test validity, it has to do with, of course, the serological tests are very robust for the finding of PLA2R antibodies. However, these tests never have a 100% specificity. So there will be very rare cases where false positive results will be given by the tests. Moving on from the diagnosis to treatment, again, the finding of the PLA2R, or the identification of the role of the PLA2R antibodies in the kidney, have been very important, because the treatment of these patients can be based on the immunologic activity of the disease, and not only on the damage scores like proteinuria and kidney function, which show both kidney damage and the activity of disease. So what many studies have shown is that the decline of the PLA2R antibodies upon immunosuppressive treatment is much more faster than the decline of proteinuria, helping us find out whether our treatment is working much faster. In patients who have had a remission of proteinuria but remain PLA2R antibody positive, they have much higher risk of a relapse of disease. Thus, also here, identifying patients at risk for relapse will be much better. And if you consider at the time of the biopsy, which parameters would help us to better prognosticate how the kidney function of the patient will develop in the next years, the best predictors of the kidney function at the time of the biopsy are the PLA2R antibody levels and the level of tubular atrophy and interstitial fibrosis, again showing that the scarring level in the kidney provides important information concerning the prognosis of the patients. This finding has led to the change in the KDIGO guidelines concerning the treatment of membranous nephropathy, where we still have our four risk categories for patients with membranous nephropathy. The low risk being patients who have very low antibodies and have no nephrotic proteinuria. These patients have very low risk, so no immunosuppressive treatment must be commenced immediately. Then we have the differentiation between the moderate and high risk. This differentiation is based on proteinuria level, kidney function, but also the level of PLA2R antibodies, where the treatment might be important to start treatment immediately, or a wait-and-see approach might be considered. And the patient with very high risk, which need an immediate treatment because the kidney function is being lost. So what I described until now for the diagnosis and treatment of membranous nephropathy is based on data on PLA2R, on the PLA2R associated form of disease, because of two reasons. The first reason is the PLA2R has been known for the longest time, and the second is that most patients with this disease has PLA2R associated disease, thus leading to more data being available. So if you consider the follow-up of the disease, in the different time points of the disease, we can use the biopsy and the serology for diagnosis and treatment decisions. In the very early phases of disease, where proteinuria has not yet developed and the antibodies are extremely low, only a kidney biopsy would lead to the diagnosis. This might be, for example, the case in patients after kidney transplantation will have a very early relapse or a very early recurrence of disease. During the active immunologic and clinical disease phase, the diagnosis can be made by serology and biopsy, and treatment might be directed by the serology of these patients. If the immunologic activity has gone down to zero because of immunosuppressive treatment or spontaneously, then again, only the biopsy would lead us to the correct diagnosis, and the treatment, we would not need an immunosuppressive treatment anymore, but only nephroprotection. As I said, these data are only based on PLA2R associated disease, because for the other antigens, no such data level is possible to make such decisions. However, the finding of these other antigens might be clinically relevant, because for each antigen, some specific clinical characteristics have been shown. For example, for THSC7A associated disease, there is a malignancy. Malignancies are more often. For NEL1 associated disease, these patients tend to have a better prognosis, and the disease associated with specific medications or malignancies. Some of these antigens are associated with lupus nephritis, like exostosine or NCAM, and some other are associated with very specific diseases, for example, FET1 with hematopoietic stem cell transplantation, or contactine with neurological diseases. So how do we move on from here? Of course, in membranous nephropathy, this major development has been made possible by the identification of these antibodies. In FSGS and minimal change, also the search for a potential antigen of potential circulating factor leading to these diseases has been going on for decades. However, no real target has been identified until now. There has been a very interesting finding 2 years ago, where in patients with minimal change disease, in some patients with minimal change disease, anti-nephrin antibody were identified in the circulation. Importantly, in these patients, the anti-nephrin antibodies were higher at the time where the disease were active compared to the times where the disease were inactive. The colleagues also stained the kidney biopsy of these patients for IgG, and what they saw was kind of a sprinkled, very low IgG positivity in the glomeruli of these patients, which is, of course, very different from membranous nephropathy, but which is not seen in all other healthy kidney tissue or in the patient with minimal change disease who did not have the circulating anti-nephrin antibodies. In a case study within this paper, the authors identified the patients who had minimal change disease with anti-nephrin antibodies, got a transplant, and had a very early recurrence of the transplant of the FSGS in the transplant. The patient was treated with plasmapheresis, rituximab, and the proteinuria went down. And in this patient, they also analyzed the anti-nephrin antibodies, and they saw that the anti-nephrin antibodies were positive pre-transplant and post-transplant, and upon treatment, these antibodies disappeared, and at the same time, the proteinuria went down. So these data are very, very interesting. Of course, this is only a single study, so much more study must be performed to validate this finding and analyze whether A, these data can be validated by other laboratories, B, whether larger patient cohorts confirm these data that the nephrin antibodies are specific for minimal change disease and FSCS, and they are correlated with the proteinuria, and of course, to specify whether these are pathogenic antibodies, for example, in an animal model. However, we will be interested, so we are very interested and eager to wait much more data on this theme. So to summarize, the kidney biopsy has a central role in the diagnostic algorithm of immune-mediated glomerular diseases. In some GN disease entities, serological testing can make the kidney biopsy unnecessary, most notably in patients with PLA2R-induced membranous nephropathy, or better to say in some patients with PLA2R-induced membranous nephropathy. And a better characterization of disease pathomechanisms may lead to more specific and non-invasive tools for a diagnosis, treatment, and prognosis of these patients. Thank you for your attention.
So thank you very much. Now it's we hand over to Peter Boor to comment and ask questions.
Thank you very much, Annette. Thank you, Elion. Really nice talk. Maybe I will ask the first question. Just out of curiosity, how do you currently approach the more personalized approach to kidney biopsies in membranous in your center? Do you still biopsy all, or you really guide the diagnosis only on serology? Maybe this might be not representative as a main center for research in membranous, but I would be curious to hear your thoughts on that.
Yes, so we don't biopsy all patients, but we are also not there yet to say we biopsy none of the patients. So we discuss with every patient who is PLA2R antibody positive how we move on. So for the patients who have like diabetes or who has impaired kidney function and so on, they all get a biopsy. In patients who have, for example, anticoagulatory treatment for any reason, they all don't get a kidney biopsy. So these are the easy cases. So for the cases in between, then we discuss with the patients what would be the benefit and non-benefit, and we decide in a case-by-case whether we do the biopsy or not. One reason would also be, for example, we will need a treatment right now, or can we wait for the treatment to be started? So a patient has proteinuria of 30 grams, antibodies are positive, but not that high. So we wouldn't start a treatment anyway. So in these patients, we can also wait a little bit and say what happens. So it depends on the case by case.
And then the second question, well, what I was interested in is this plethora of antigens that we now have for membranous nephropathy. And I was wondering how do you envisage to bring this into the clinical routine? Now I'm talking about a little bit of a pragmatic diagnostic approach. Membranous nephropathy is not a very common disease. And then having one antibody tackling 70%, that's already, from a diagnostic perspective, not an easy biomarker. But tackling then an antibody, which in I say medium nephropathology you would use twice a year, just doesn't pay off. So maybe my question, do you see any possibility how to tackle this in the future? And also another question which tackles this is what I was wondering, would you really rely on this? So if you would find a specific antigen, would you really not test and search for malignancy, or search extensively for malignancy? So I'm not sure if we have the data, but this would be maybe of interest.
Yes. So what we do is, I think because the PLA2R is so often, I think both in the biopsy and the serum, we first test for PLA2R, because if they are positive for PLA2R, then we go with the PLA2R. And then the question arises, what to do with the rest? So on the serology part, we would perform a multi-antigen test. So trying to have as much antigens or as much antibodies being provided or being tested by one test alone. This is what we are trying right now to establish such a protocol. This would be not that easy because all antigens are different and the specificity is a problem. So the question moving along would be which of these target antigens are real target antigens. So until now, these are proteins which have been found in patients with membranous nephropathy. This is how we should consider them. So at least, except for PLA2R, THSA7A, and NEL1 up to a point. The other antigens are still with a question mark. Until then, we need more data. So if a patient has like the antigen X, I would not be confident enough to say, okay, the membranous nephropathy caused by this antigen, we don't do this or we do that, or we treat based on these antibodies, because the studies are not validated. Most of the antigens are one paper with very few patients. So I think we will need more data before we are confident saying that this plethora of antigens are indeed the pathogenic antigens for each disease. So
may I add a question? Do you see that really the patient management would really change between these different antigens?
Well, in L1, for example, yes. In L1, we see that we have a cohort of 20 patients. 80% of them have spontaneous remission of proteinuria. So we are now reluctant starting immediately an immunosuppressive treatment if a patient has an L1 membranous nephropathy. But there we would look what medications they have, what do they have a malignancy and so on. So we would wait a little bit longer until we decide. For THSA7A, we do a very intensive cancer screening. So in these cases, we indeed change our management. But if a patient has now a HTR1 positivity, there I don't know, because the data are not there yet to change management yet for this antigen.
Okay.
Great. Thank you very much. I think most of the questions in the chat have actually been asked by the panelists and answered by the speakers. We'll see here. Yeah, I think so, actually. So that gives me a chance to ask a question. So I wanted to ask you about this familiar IgA nephropathy patients. Who should we test and when? That's back to
that's a question for me, I guess.
Yes.
Yeah, I'm not sure yet. The story of familial IgA has been around for years, and they are probably true familial form, even if it's not monogenic. But I personally have the example of 3 families that were identified as familial IgA and turned out to be autosomal dominant Alport syndrome. Specifically, you know that you can have non-specific IgA staining in many biopsy, and even in the general population, probably a few % of the kidney biopsy show some deposit of IgA non-specific. So I really think it will be tested in any case of apparently familial IgA nephropathy. Maybe you can ask Danny what is his point of view regarding this genetic part.
Yeah, I mean, we know that there are now lots of cases in the literature, particularly in the last 2 to 5 years, where whole exome sequencing has been widely used of familial IgA nephropathy, and we described some cases, and there's lots in the literature. In most cases where you diagnose IgA nephropathy, somebody in the family will have had a kidney biopsy. And the most logical first step would be to get electron microscopy on that and see if it's compatible. Because IgA also has very strong genetic contributing factors, it can cluster, not as a Mendelian trait, but just because we know in Kentucky and Italy particularly, there are a very large series of multiple families affected. So I think it is difficult. I think if you've got clear autosomal dominant inheritance and maybe you don't have biopsies available, then genetic testing might be the way to go. You can, of course, have IgA nephropathy in one family member and a heterozygous COL4 mutation segregating in other family members.
Absolutely, I've seen that.
Exactly. So then you do the genetic test in the person with IgA nephropathy, they don't have it, and you've missed the diagnosis in the rest of the family. So it can be a very difficult question. I don't think there's an easy answer to give at this point.
But you have really to be aware of that and not say it's a familial IgA nephropathy.
Correct. There's no Mendelian IgA nephropathy described.
Yeah.
Thank you.
Bertrand, can you quickly summarize in which patients the clinical suspicion of Alport is good enough for you to spare biopsy? So in which situations would you spare biopsy?
More and more we spare biopsies when we suspect Alport syndrome. If there's a strong family history, of course, if there are and family history with one proven case of Alport syndrome, genetically proven or proven by electron microscopy or immunohistochemistry. In case of extrarenal symptoms, very suggestive of, but you have to be aware that hearing loss is very frequent in the general population, and even genetic form of hearing loss are very frequent. So it's not because you have a patient with glomerular hematuria and hearing loss that he has Alport syndrome. And I've seen in many, many cases the wrong attribution of hearing loss to Alport. But the strong familial history of hearing loss and glomerular disease, of course, it's very suggestive. So the more it goes, the more we do a genetic test first, and we do not perform a kidney biopsy.
Yeah, thank you very much. I think
but in the case the genetic test is negative, then we return to the patient and perform kidney biopsy with electron microscopy and with immunostaining for type 4 collagen chains.
Yeah. Thank you very much, Bertrand. I think in the interest of time, we have to wrap up, and I thank you very much for keeping in time and for discussing this very large topic, but starting from the clinical side, from haematuria, proteinuria, and then taking the perspectives from genetics and from immunological kidney diseases was very interesting. And I think we have to bear in mind that kidney biopsy, different from previous times, is in some situations is not the first diagnostic tool anymore, but it's genetics or it's serological analyses, and we always have to individualize our diagnostic steps more often than we used to do this. So thank you very much for your interest in this seminar, and I wish all of you a nice evening, and see you next time.